And the objectives of today's talk will be to classify the common fibrosing skin disorders with systemic involvement. We will briefly describe the clinical manifestations and complications of systemic sclerosis. For time constraints, I will not have time to discuss the other conditions that will affect the skin and cause fibrosis. We will discuss the current evidence-based management strategies of skin fibrosis in systemic sclerosis, and we will discuss investigational therapies. So the common fibrosing skin disorders with systemic involvement. I think that's important because we as rheumatologists take care also of their systemic manifestations. So the most common one that we take care of in rheumatology and in conjunction with the dermatologists is systemic sclerosis or scleroderma. We also see patients with scleroderma adultorum. We see patients with nephrogenic systemic fibrosis, much less so since the recognition of the association of gadolinium-based contrast agents in end-stage renal disease patients. And we follow those recommendations, and the prevalence of this has gone down. We take care of patients with diffuse fasciitis with eosinophilia, formerly known as eosinophilic fasciitis. Every now and then we encountered such patients. We also take care of, much less commonly, patients with scleromyxedema or lichen myxedematosus. And every now and then also we are encountered with patients with chronic graft versus host disease. So what is systemic sclerosis? It's an autoimmune disease of unclear etiology, and it is characterized by progressive skin thickening, occlusive microvasculopathy. There is variable degrees of internal organ involvement and also immune abnormalities in the presence of certain autoantibodies. So the key clinical features that will be relevant for a dermatologist are the skin manifestations. Oftentimes patients start with Raynaud phenomenon, and soon after that they develop some puffiness of the fingers. Sclerodactyly comes later. Nail fold capillary abnormalities, which is something that we evaluate in somebody presenting with Raynaud phenomenon in the clinic, and we are trying to ascertain is this primary or secondary Raynaud's, something that can be done. We have a capillaroscope, and we look at those. And also later on, patients develop digital pitting scars and ulcers. The skin tightness usually starts distally and moves proximally. And in patients with diffuse cutaneous systemic sclerosis, it does affect the trunk, whereas in patients with limited scleroderma, it's only confined to the distal extremities and face. There is pruritus, which is a problem all the way through the course of the disease, but particularly in the early part of the disease. Pigmentary changes, hyperpigmentation, and this classic salt and pepper skin. Telangiectasias and calcinosis, as we discussed earlier, is a problem in dermatomyositis, but I would think much more so in patients with systemic sclerosis. The systemic manifestations which largely determine the prognosis in these patients include interstitial lung disease, pulmonary arterial hypertension, dysmotility that can affect just the esophagus, but sometimes the entire gastrointestinal tract, joint contractures. Renal crisis can be a life-threatening problem, presenting early in the course of the disease. Inflammatory arthritis, scleroderma, myopathy, and cardiac scleroderma. So these autoantibodies can help us, recognize this entity, also put patients in different categories. The centromere antibody typically associated with limited cutaneous systemic sclerosis, whereas SCL70 and RNA polymerase III antibodies typically associated with diffuse scleroderma. The other scleroderma-associated antibodies, which are PMSCL, THTO, and U3RNP, and there are a few others. These are much less commonly encountered. So the types of scleroderma, one that is confined just to the skin, called localized scleroderma, and there are different subtypes of it, morphia, linear scleroderma, and Cody Sabre, whereas systemic sclerosis, which is both limited and diffuse cutaneous subsets. So the localized scleroderma, these patients develop painless, discolored, indurated patches, but without any internal organ involvement. The types, as I mentioned earlier, morphia, linear scleroderma, and Cody Sabre. So this is a patient with morphia. You see these plaques or indurated skin surrounding erythema indicating activity of disease. And over time, the patients with or without treatment can spontaneously regress. Oftentimes, these patients do not have any internal organ involvement, and mostly seen in children, but sometimes we have patients, adults, presenting to me. I often resort to, help from the dermatologist. I refer the patients to Dr. Fernandez and also Dr. Warden and a few other colleagues in dermatology because we need help managing these patients. This is linear scleroderma. Histologically, under the microscope, the skin changes in morphea or linear scleroderma are indistinguishable from what you can see in patients with systemic sclerosis. So this is on Cody. Basically, there's this depressed scar on the forehead. It goes into the scalp and the hair loss. Patients can sometimes get dural calcification also and seizures. So our focus today is to talk about systemic sclerosis. So along with skin, there is always some degree of internal organ involvement, severity of which tends to correlate with the extent of dermal fibrosis and skin tightness. The exceptions being pulmonary arterial hypertension and severe gastrointestinal problems. So the limited cutaneous form, which used to be called CREST syndrome, has been renamed limited cutaneous disease because all the 5 components, CREST, are not required. 2, 3, or 4 out of the 5 can be present. So patients can have involvement or tightness of the fingers, hands, forearms, feet, legs, and face. However, the proximal extremities and the trunk are spared. There is one subset of patients who have systemic sclerosis sine scleroderma. So these patients do have no skin tightness whatsoever, including fingers and distal extremities. So they, however, behave similar to those with limited scleroderma. They have the phenotypic, presentation very similar, and long-term outcomes and complications are comparable to those with limited cutaneous systemic sclerosis. The diffuse variety, however, have much more extensive skin hardening, a rapid rate of progression, the time lag between Raynaud phenomenon and the non-Raynaud manifestations, much shorter in those with diffuse disease. The skin tightness progresses proximal to the elbows, proximal to the knees, and affects the trunk. There's a more rapid rate of progression. They also are at high risk of major internal organ involvement. So how do we evaluate skin tightness, which is what scleroderma means? So we do it at the bedside. So the left dorsal hand is showing normal skin thickness, whereas the right one shows increased skin thickness. So we use our index finger and thumb to pinch the skin and try to palpate the skin and try to assess at the bedside the amount of skin thickening. This is relevant because we tend to do a modified Rodnan skin score at the bedside. This is a recording sheet. So we are looking at the body at 17 different areas: fingers, hands, forearms, arms, feet, legs, and thighs in pairs, plus face, chest, and abdomen. Total 17 areas. 0 is the score given to uninvolved skin, and 3 is given to a score where the skin is totally tethered, height-bound, and cannot be moved at all. And mild and moderate thickening gets a score of 1 and 2. So this patient, for example, has a total skin score, and which is corrected, documented in this sheet of 25, and the patient has diffuse scleroderma. And this is relevant because the amount of skin tightness correlates with the amount of dermal fibrosis. And that in turn tends to correlate with the amount of fibrosis happening internally, affecting the GI tract, lungs, heart, and kidneys. So in the first 5 years after onset of disease, the skin score keeps going up, particularly in those with diffuse scleroderma. Then it tends to stabilize, and this is regardless of any intervention, any pharmacologic intervention. And then it starts to spontaneously get better. And the progression happens from distal to proximal, and the regression happens from proximal to distal. So the part that hardens last in those with diffuse scleroderma softens up first. And this is some kind of hope that we can offer to our patients, because this disease doesn't have, unfortunately, a whole lot of disease-modifying therapy. And we can at least tell them that if you wait long enough, if all you have is skin disease and not much of major internal organ involvement, be aware that chances are over time your skin will soften up. And if that's the case, some patients choose not to, go for any pharmacologic intervention. They will just wait it out, considering the potential risk of some of these medications that we offer these patients. So this is somebody with early scleroderma. Patients have these edematous hands. Over time, this is a patient of mine. You can see the contractures, the ulceration over the knuckles, the skin, the contractures, the pigmentatory changes that are seen, and the tethered hidebound skin. Obviously, this cannot be ascertained just looking at a picture, but this is a very frustrating situation, and they do not have a whole lot of good pharmacologic intervention that can help take care of these contractures. So we are going to talk about management of skin tightness in systemic sclerosis. Modified Rodnan skin score is the primary outcome measure in most of the studies that have been done. The available therapies with evidence of some efficacy would be methotrexate, the age-old drug that has been used over the years. We have some data on mycophenolate mofetil, data on cyclophosphamide, which I'm not going to discuss. So the ones that are underlined and asterisked are the ones that I will be talking about today. But the slide deck that will be provided later on has data on all of these. Rituximab has some information. Intravenous immunoglobulin, I particularly have been quite impressed in those patients in whom this drug was made available through the insurance, which is not always easy. And tocilizumab have some interesting data available. We have this, we already heard about Lenna Bassem once before. So, and we also heard that this drug has been also found to be effective in a phase 2 study in patients with systemic sclerosis. We will not discuss belimumab. There is some signal about the efficacy of this drug. Phototherapy and photophoresis is also in the domain more of dermatology. But when we need help from our colleagues in dermatology, we refer patients to them. And then we will talk about autologous hematopoietic stem cell transplant, which has shown significant promise and is probably the way of the future, at least in a subset of patients with rapidly progressive disease. So let's talk about methotrexate. 2 placebo-controlled randomized trials have been conducted. These were quite old studies, one from 1996, one from 2001. The first group is from the Netherlands, the second group from Canada. And you can see the patients were followed either over 24 or 52 weeks. The other information about the patients are listed here. The second study, which is Janet Pope, her group, 100% of the patients had diffuse scleroderma, whereas the first group, only about 1/3 of patients had diffuse disease. So this is the data that we got from those 2 studies. So the patients were followed over 24 to 52 weeks. I think the average dose of methotrexate was 15 milligrams a week, and there was a drop in the skin score in the methotrexate arm in both the studies, more so in the second study, which was a longer duration of follow-up. And if your skin score is low to start with, you don't expect a whole lot of a drop, because only 1/3 of patients in the first study had diffuse disease and the remaining had limited disease. We would not have expected as much of a skin score reduction with any pharmacologic intervention. So members of the Scleroderma Clinical Trials Consortium, which is a group that is international group, and also the Canadian Scleroderma Research Group. So this was again a Delphi exercise that was performed, 117 responders, and they were surveyed through a Delphi exercise. 3 different scenarios were developed with increasing severity of skin involvement. Because we do not have a whole lot of good quality evidence-based data, we wanted to know what the experts would do. The so-called scleroderma specialists, how would they manage their patients with severe skin tightening? So the first group had a modest low skin score of 10, second group 24, and third group 32. In each of these groups, the consensus opinion, majority suggested methotrexate should be the first line of treatment for skin disease. And if that was either ineffective, they could be adding mycophenolate mofetil as the second agent. My own experience, however, has been I've been more impressed with the effects of mycophenolate mofetil as opposed to methotrexate, and we can ask the panel later on whether there's any other experience. But majority suggested in all the 3 groups to add mycophenolate. 77% suggested that, as opposed to switching to mycophenolate. And steroids were used every now and then. And there was about 78% who agreed that in spite of the risk of precipitation of renal crisis, investigators or physicians taking care of these patients would offer steroids, short courses of it. I am not entirely sure whether steroids have a big role in the management of scleroderma. It is probably very different than managing rheumatoid arthritis, lupus, myositis, vasculitis. We have to really justify the need for steroids in this group. I have not personally been, quite, impressed with the effects of it, and obviously the concern of renal crisis is always there. And I have seen patients go into that situation. Oftentimes, patients presenting with swollen hands, painful joints, and the primary care provider, just has to offer a course of steroids. Next thing you know, they get admitted to the hospital with renal crisis. The RNA polymerase 3 antibody, which is associated with renal crisis, is not in the ENA panel. So the ENA is negative. That means SCL70 centromere negative. So let's try steroids and some devastating consequences. Mycophenolate mofetil, I think this is a drug that I have been quite impressed with. How does it work? It reversibly inhibits inosine monophosphate dehydrogenase. It impairs purine synthesis and lymphocyte proliferation. It has both antifibrotic and immunomodulatory effects and may have a role in improving skin sclerosis. Two small studies were conducted, one open label, these were both open label studies, so the control arm was not there. They showed significant skin improvements in diffuse scleroderma. The problem with skin studies is, as we discussed the natural history of the skin disease, the skin gets tighter, it reaches a steady state, and then starts regressing. So if a patient is offered a therapy and the skin starts softening, is it the natural history of the disease, or is this an effect of the pharmacologic intervention? That's not always easy to understand. So the second study actually also looked at skin that's the Mendoza is the first author of that paper, that showed a decrease in the thickness of collagen bundles in the dermis in 3 patients who underwent skin biopsies before and after mycophenolate therapy. So this is an interesting study. This was actually published by Walkman et al. Last year. So basically what was done, 2 groups were compared. One is the placebo arm of the scleroderma lung study 1 was compared against the mycophenolate arm of the scleroderma lung study 2 patients. So scleroderma lung study 1 was a 1-year study comparing oral cyclophosphamide and placebo in patients with interstitial lung disease in scleroderma. However, among the secondary outcome measures, skin score was documented in these patients. The second study was published much more recently, looking at the effect of and comparing mycophenolate mofetil to cyclophosphamide for interstitial lung disease in scleroderma. Patients received either 1 year of cyclophosphamide followed by a year of placebo, and the control arm was 2 years of mycophenolate. So the way to do this comparison, because there was no control trial looking at mycophenolate on skin disease, so they looked at the 2 arms and they compared the 2. So the MRSS change, as I said, was the key secondary outcome measure. So joint models were created to evaluate the treatment effect on the course of the outcomes over the 2 years. So this is what we just talked about. So the SLS2 patients assigned to receive MMF are this arm here, and the other one is the placebo arm of the scleroderma lung study 1. So this was a way to assess the effect of this intervention with a control group. So what was found was, from 3 to 12 months, patients in the MMF arm experienced a significant decrease in the MRSS compared with those in the placebo arm. And this was statistically significant. This improvement continued from 12 to 24 months. So as you can see here. Patients in the placebo arm experienced an increase or worsening skin score in the first from 3 to 12 months. And then they followed a decline, which could be the natural history of skin softening in the following rest of the study. And this was associated with a stronger treatment effect in patients with diffuse as opposed to limited disease, which is understandable. We will move on to tocilizumab, interleukin-6 inhibitor. IL-6 is overexpressed in scleroderma skin and may play a unique role in moderating endothelial cell dysfunction. This was an 83-patient placebo-controlled study. It's a phase 2 study. Phase 3 study is currently ongoing. So I'm going to present the data on this study. So basically, it's these fancy names, right? Fascinate study. And the SSC stands for scleroderma. So improvement in MRSs were observed during the double-blind phase, which is up to week 48. And I'm going to show the graphs in the next slide. And then there was an open-label extension. So the initial drop in the skin score in the double-blind phase was minus 5.6 compared to the control arm. And that went down to minus 9.1. So this significantly improved skin scores in patients receiving the drug versus placebo. Patients in the placebo group experienced similar improvement after the open label extension started because they were also getting the drug. So this is basically the two graphs. The first part is the randomized phase of the study. The second part is the open label extension. So the top line indicates patients receiving placebo. The skin score does go down, and for sure from here they're getting the drug. The second line is patients who have been receiving tocilizumab from the beginning, and their skin score was lower. They were kind of comparable here, but there was a significant difference between the two arms, and this actually was the reason we are looking at a larger scale phase 3 study, and now it's called focused study instead of fascinate. So this is a phase 3 clinical trial evaluating tocilizumab for scleroderma, and we are going to be waiting and anxiously to see the effects of this intervention. Intravenous immunoglobulin. We do not have good quality data, unfortunately, but there is evidence supporting the use of IVIG for scleroderma. So a small study, and this was what was published, open label study, 15 patients demonstrated that monthly IVIG, 2 grams per kg over 5 days was associated with significant decrease in MRSs of 30%. So these are the initial scores of the skin scores, and these are the follow-up except one patient, everybody's skin score did drop. However, there is no control arm. So that makes it hard for us to know whether this is the natural history or is this an effect of the intervention. 11 patients were treated for 6 cycles, 3 patients 4 cycles, and these are monthly cycles of IVIG, 2 grams per kg, and 1 patient received 3 cycles. This is our own Cleveland Clinic experience. So these are patients who are lucky enough to get this IVIG approved through their insurance, and we have variable duration of follow-up, and then there is no control arm, but at least we have been impressed with the drop in the skin score in each of these patients. However, some responded better than others, so there is variability in the response, but also they had improvement in their pain, their contractures, their muscle weakness, all the musculoskeletal manifestations of scleroderma actually got better in these patients, and they were willing to talk about it, and that it's not only that they get benefit from the in terms of their skin scores, but also musculoskeletal symptoms got better. Lenna Bassem is the drug that we already heard about. So this is a selective cannabinoid receptor type 2 agonist. The beneficial effects are on these, and you can see this in the slides. It increases clearance of cellular debris, and also helps resolution of tissue infiltration with inflammatory cells. So this was a study that was completed, a phase 2 study. Our phase 3 study is ongoing, and we are participating in the study. So basically the results show it helped with the MRSS scores, helped with the skin symptoms, and also with itch. As we heard earlier, it was helpful for reducing the amount of pruritus in patients with dermatomyositis. So all these were benefited, and early on, within 4 weeks, the patients showed improvement in all the 3. So the placebo is on the top, and the blue line is JBT 101, which is Lenna Bassem. This is the last part of the talk. So autologous hematopoietic stem cell transplant. It has emerged as a potentially effective treatment option for carefully selected patients. So early trials demonstrated the feasibility of this kind of aggressive therapy for patients who are rapidly going downhill. Obviously, we are not going to offer this just for the skin disease, but they have major internal organ problems and they are not going to make it for too long. However, if you select your patients and select the sickest patients, that may not be the right population to offer this treatment. So 3 randomized clinical trials were conducted and they were actually all published. The single center study called ASSIST, this multi-center European study called ASTIS, and multi-center, this is the latest one published recently called SCOT study, that's the American study. So the patients were comparable in all the 3 groups, and the trials demonstrated a benefit in HSCT with respect to primary endpoints. So that will be demonstrated here, the drop in the skin score in those who got hematopoietic stem cell transplant compared to IV monthly cyclophosphamide. So that was the control arm in all the 3 groups, all the 3 studies. So that showed some rise in the skin score. I just selected out the graphs that are representing the changes in the skin scores. The study is obviously published and looked at lung function and all other quality of life measures, etc. The same thing happened if those patients were followed in the ASSIST study for from 12 to 24 months. The skin score continued to drop and significantly better than those who received cyclophosphamide. This is the ASTIS study showing the area under the curve, time response curve for baseline to 2 years follow-up in the skin score. The treated arm with stem cell transplant dropped their skin score significantly, 19.9 points, whereas the control group, which is IV Cytoxan, only dropped 8.8. The difference was statistically significant. And this is the SCOT study, which is again showing the benefit. The improvement was seen in all patients who received transplant versus those who got cyclophosphamide. Some did not change and others actually worsened. So these are some other attempted therapies for skin tightness in systemic sclerosis. Either they were ineffective or there was some controversy. So we have a long list of a lot that's been tried over the years, and I'm not going to read out these agents. And then this is oral type 1 collagen oral tolerance study that was published a few years ago by Postlethwaite et al. Post-hoc analysis demonstrated cutaneous improvement, interestingly, in the late patients, not in the early patients. These are some other ongoing studies. Abatacept, which is ASSET study from University of Michigan, and we are participating in that. We are also participating in this study. It's a dual monoclonal antibody against IL-4, IL-13. This is a study that we are also participating in, selective cannabinoid receptor type 2 agonist, but this is a phase 3 study. And this is riociguat, which is soluble guanylyl cyclase stimulator.